Stop share.
Sorry? Hi, good afternoon, everyone, and welcome to our live webinar on CT imaging and AI in COVID-19. This webinar is organized by the College of Radiologists Singapore, the Academy of Medicine Singapore, the Singapore Radiological Society, in collaboration with Siemens Healthineers. I'm Dr. Teh Kiang Heong. I'm a radiologist with the Singapore General Hospital. I'm also the current president of the College of Radiologists Singapore, and I'll be the moderator for today's session. Before we begin, I'd just like to go through a few housekeeping rules. So all participants will be muted so that our speakers will not be interrupted during their presentations. For local doctors, there will be 1 CME point accorded to those who have attended the entire session. We will be recording this session and we will post this at our college website subsequently. And the question and answer session will be at the end of the session after all three speakers have given their presentation. For those of you who want to ask questions, please use the Q&A function, which can be found at the bottom of the Zoom app to ask your question. Today, we are very happy to have three distinguished speakers to share their expertise as well as their insight. So without further ado, I would like to introduce and welcome our first speaker. He is Professor Savas Nicolau. He is the Director of Emergency and Trauma Imaging at the Vancouver General Hospital in Vancouver, Canada. He will be speaking on the role of CT in the acute setting of COVID-19. Prof. Nicolau, please.
Thank you. I just want to thank the organizers and the Academic College of Singapore for inviting myself and Dr. Omar Nasir to present here today. And Dr. Nasir is one of my esteemed colleagues, and Dr. Parker as well. So thank you so much. It's a privilege and an honor for us to present today. So today I'll be talking about CT in the acute setting of COVID-19. So coronavirus COVID-19 is caused by the novel severe acute respiratory syndrome coronavirus type 2. Now, during the viral infection, the host...
Dr. Savas, sorry,
yeah.
we haven't seen your screen. I think you need to click share.
Okay, 1 second. Let me just...
Yeah.
Okay. Share. Yeah.
Yes, now we can.
Back. Sorry about that. Here we go.
There we go.
Can you see it now?
It's still white though.
No?
No, it's white.
Okay, let me just do something. Can you... Let me just try one last time. Sorry about that. Let me just share right here. New share. There we go. Can you see it now?
No, it's still a white screen though.
Oh, white screen. Okay, just 1 second. One second. I'm just going to quickly shut it down. Okay. Share screen. I don't know why. Let me just do this. Let me just share again. You share. Screen sharing. Is it? Can you see it now?
Yes. Now we can.
Great. Sorry about that. Okay, so we'll start over. I just want to thank the organizers and the Academy of Radiologists Singapore for inviting myself and Dr. Omar Nasir and Dr. William Parker to present today. It's an honor and a privilege for us. And today I'll be talking and starting off with the role of CT in the acute setting of COVID-19. Now, coronavirus, COVID-19 is caused by the severe acute respiratory syndrome, coronavirus type 2. Now, during the viral infection, the host response triggers a rapid surge of inflammatory mediators, including neutrophils, monocytes, and chemokines, particularly interleukin type 6. Now, recent literature suggests that, COVID-19 or SARS-CoV-2 is particularly a disorder of vascular dysfunction, thrombosis, and dysregulated inflammation that maybe leads us to better understand how to better develop appropriate therapeutic responses to this disorder. Now, this is a very complex slide, but basically what I would like to draw to your attention is throughout the course of the disease, there's basically a vascular dysregulation with a significant amount of inflammatory mediators, with endothelial dysfunction that progresses from the initial onset of the disorder to the late phases that causes microthromboses within the lung parenchyma that leads to vascular distension and abnormal the loss of the normal vasoconstriction of the pulmonary vasculature in areas of abnormalities that leads to significant right to left shunting and leads to VQ mismatch and also leads to hypoxia. Now, the clinical features are lower respiratory manifestations. Some of the signs are very nonspecific that include fever, which is now recognized not to be as common, productive cough, fatigue, shortness of breath, nausea, vomiting. Less common symptoms include myalgias, headaches, sore throat, chills, gastrointestinal symptoms, such as diarrhea are less common. Anosmia and hyposmia is seen up to 2/3 of patients, common in children and young adults. Now, the mild disease, moderate disease, severe disease, and critical disease are the different stages that this is characterized. And the mild disease is characterized by a lack of radiographic evidence of pneumonia on chest radiography and a peripheral capillary O2 saturation of greater than 94%. Mild disease has imaging findings of pneumonia or a saturation oxygen level of less than 94%. Severe disease is characterized by a saturation level of less than 94% at rest, requiring O2 supplementation with high flow nasal cannula and non-rebreather mask, positive airway pressure or mechanical ventilation. And critical disease is characterized by respiratory failure, requiring significant O2 supplementation with signs of extrapulmonary and organ damage, including cardiovascular collapse. Now, diagnosis is usually confirmed with the gold standard, which is a PCR, either nasopharyngeal or oropharyngeal swab test. High specificity. The sensitivity, though, does vary depending what literature you do read and what study has been published, but is reported anywhere between 60 to 70%, all the way up to 95%. But usually, my understanding, speaking with a microbiologist at our institution, usually it is due to insufficient viral load or a failure of nucleic acid extraction from the actual nasopharyngeal or oropharyngeal swab test. One thing to remember, the PCR test does not really tell us about active disease. It only detects the viral RNA. Now, baseline non-contrast CT for the role of imaging. We believe strongly at our institution that a baseline non-contrast chest CT should be considered in all patients with suspected COVID-19 who have an indication for hospital admission, particularly in areas where there's non-availability of PCR testing, and that has occurred, particularly in Iran, where they did not have availability of PCR testing because of sanctions against Iran, CT played a vital role in the diagnosis and management of COVID-19. CT also supports the diagnosis in case of false negative PCR testing with a high clinical suspicion, and we've seen a lot of these cases at our institution. Also, CT is very useful for the severity and extent of disease involvement. It can serve as a treatment guide and also responds to different novel therapeutic regimens. Now, chest radiography. What is the role of chest radiography? Routine chest radiographs, usually PA and lateral views, are the first line of investigation, but usually, to be honest, it is portable radiographs, given that these patients are usually ill, either in the ED, up on the floors in the different wards within the hospital, or in the ICU. Now, the chest X-ray findings have a lower sensitivity than PCR testing, particularly in the acute phase is what I would say. And it's commonly reported that chest X-rays can be normal where the abnormalities are present on CT. But chest radiographs can be helpful, particularly in the ICU population. They'd be helpful with some of the complications that can ensue, such as misplacement of tubes or pneumothoraces or pneumomediastinum that could develop. Now, the early chest radiograph findings can be normal, as I've stated, 0 to 2 days after the onset of symptoms. They can also be normal. You might see a hazy opacification. These opacities sometimes can be rounded in morphology and usually have a lower lobe predominance, particularly within the right lower lobe is what has been reported where the pathology initially could originate. The lung findings may be unilateral rather than bilateral, or they can be spotty in diffusely throughout both lungs. Isolation within the upper lobes is uncommon. Now, chest X-ray findings in the intermediate phase, 3 to 9 days after the onset of symptoms, can be unilateral, bilateral. Involvement mid to upper lung zones starts to predominate. The chest X-ray findings in late phase, usually described at 10 to 12 days after the onset of symptoms. These opacities may coalesce and become denser and more consolidative and more diffuse throughout both lungs, with diffuse opacification mimicking diffuse alveolar damage or acute respiratory distress syndrome. CT techniques, and usually there's been in the literature reports that low dose chest CT is just as accurate as a routine chest CT for the diagnosis of COVID-19. And there's been some literature that's been published on low dose sub-millisievert chest CTs that have demonstrated excellent sensitivity, specificity, positive value, and negative value, and accuracy in patients, usually with clinical symptoms for greater than 48 hours, very comparable to PCR testing. And one other thing I would say, of course, there is a role for CT pulmonary angiography and dual energy CT and even dynamic CT for perfusion that I'll speak to later on in my talk that have some significant prognostic implications and also leads us to understand why a lot of patients develop silent hypoxia. Now, indications for CT can be to identify early parenchymal lung disease because of this phenomenon of silent hypoxia that we've seen patients present even with saturation O2 levels less than 80% in the ED. The other thing about CT, particularly if there's a big surge or you're dealing with a huge number of cases that present to your institution, CT can be used in the surge during a pandemic to screen for patients in the acute setting. Definitely evaluating disease progression. Definitely, we believe very strongly, as I'll illustrate later on in my talk, that it can help with concurrent diagnoses, particularly in patients with multiple comorbidities, patients with diabetes, hypertension. CT can be very useful in those patients. And as I alluded to, CT pulmonary angiography and dual energy CT can be very useful in the detection of coagulopathies and pulmonary thromboembolic disease. The diagnostic performance of CT sensitivity has been reported, and it's different in different studies that have been published up to date. I think the real sensitivity of chest CT is still yet to be determined. There are overlapping features, though, with other disease entities that does lead to a poor specificity depending on the prevalence of disease. Now, CT abnormalities do progress rapidly after symptom onsets and peak anywhere between days 6 to 13 after the onset of the illness. A recent meta-analysis comparing CT and PCR testing demonstrated a low positive value of CT and a risk of high false positive rates in low prevalence areas of disease. In areas, though, of high prevalence that we've seen in China, in Iran, in South Korea, in Italy, or limited availability of PCR testing, particularly in Iran, the benefit of diagnostic use must be considered against the risk of radiation and infection that could be caused to the Department of Radiology and Technologies. Now, one thing I want to say about CT findings in asymptomatic patients comes from the Diamond Prince study, where 104 cases were analyzed, 76 were asymptomatic, and 54% of these asymptomatic patients did have pneumonic changes, primarily ground glass opacities. The other 28 cases were symptomatic, and 79% of these patients had abnormal CT findings. Now, the asymptomatic cases, which is extremely important, showed a higher prevalence of ground glass opacities over consolidation, where the consolidation was seen more in more severe symptomatic patients than the asymptomatic patients, where ground glass opacities were more prevalent. Now, thoracic manifestations of CT, and we're all aware of some of these manifestations. I'll talk during the dual energy portion of the talk, some of the uncommon manifestations. But ground glass opacification is defined as a hazy increase in lung attenuation with preservation of the bronchial and vascular underlying markings. Consolidation refers to denser opacification that obscures the vessel margins and airway walls. Bronchogram signs can be visualized. They don't have to be in the presence of consolidation. The atoll sign or reverse halo sign is an important sign. It's a rounded area of more loosened ground glass opacity surrounded by a complete, almost complete ring of denser consolidation. And we'll see later on the talk, this can be an important sign to prompt the acquisition of a CT pulmonary angiogram to exclude pulmonary thrombotic disease. The halo sign is defined as consolidated nodules or masses surrounded by ground glass opacity. Typical manifestations as defined by the Fleischner Society and through the RSNA Society as peripheral bilateral ground glass opacities with or without consolidation, or visible intralobular lines known as crazy paving. You could also have multifocal ground glass opacities of random morphology with or without consolidation, or visible intralobular thickening known as crazy paving, or the reverse halo sign or other findings of organizing pneumonia that occurs later on in the disease, usually at day 7 to 10. This is an area on your left of ground glass opacity, where you can see the underlying architecture of the lung with some mild intralobular septal thickening with a little bit of crazy paving. And this is the reverse halo sign, which can be a marker of pulmonary thrombotic disease. Indeterminate findings, it's the absence of the typical features, and usually you have multifocal diffuse perihilar or unilateral ground glass opacities with or without consolidation. And also you might see very, very few or small ground glass opacities with a non-rounded and non-peripheral distribution. Now, atypical findings are usually described as absence of typical or indeterminate features and the presence of isolated lobar or segmental consolidation without ground glass opacities, discrete small nodules such as tree and bud appearance, lung cavitation, smooth interlobular septal thickening and pleural effusions, and the presence of lymphadenopathy. Now, the temporal classification of CT findings, early phase, 0 to 2 days after the initial onset of the illness, are usually ground glass opacities, peripheral, subpleural distribution, posterior, and independent portions of the lung. Progression, usually at 3 to 9 days, further progression of ground glass opacities with further areas of consolidation, some intralobular septal thickening, known as the crazy paving pattern. And then further on in the late phase at 10 to 12 days, now we can start to see fractional bronchiectasis, we can see organizing pneumonia, and we can also see the presence maybe sometimes of lymphadenopathy and pleural effusions. This histogram analyzes, what are the most common findings we see, and definitely ground glass opacity is the predominant feature that we see on CT, but air trapping, bronchiectasis, consolidation, and crazy paving are not uncommon features that can be seen through the course of the disease. One thing I would say about CORADS that was developed as well by one of the Dutch groups was to make it easier and more simpler to report these types of studies, and also improve the inter-observer variability between radiologists in interpreting these types of studies. And basically it is rated from CORADS 1 to CORADS 5, where CORADS 1 is very low, with no CT abnormalities consistent with COVID-19, to CORADS 5, very high probability, highly suggestive of COVID-19. And a study that compared the RSNA classification system to the COVID-19 CORAD system was very comparable. The CORAD system had a higher inter-observer agreement. Now, one thing about dual energy and COVID-19, there's some important pathophysiology that we're starting to recognize in iodinated studies of the chest in the assessment of COVID-19. And what we're starting to see is this vascular engorgement sign, where peripheral vessels measuring more than 3 millimeters in diameter in areas of lung opacity. And one thing I would mention about that is counterintuitive, because usually in an area of lung opacity, you're supposed to have pulmonary constriction, where you redirect the blood to the areas that are normally ventilated. And that is lost because of endothelial dysfunction and a loss of the normal pulmonary arterial constriction that occurs in a normal person or in other types of pathologies. But however, in COVID-19, this is lost. So this creates an increased right to left shunt and results in significant hypoxia and different types of phenotypes that we're seeing in the presence of this disease. Now, this is some images from dual energy studies, and dual energy studies can be helpful in characterizing lung perfusion. And the literature suggests that we are having these distended vessels that we're seeing in the areas of lung opacity, and it could be due to micro thrombi initially that progresses on to vascular distension and loss of the normal vasoconstriction. And what we're seeing on dual energy iodine uptake images, we're seeing increased iodine uptake in and around these areas of ground glass opacity. So it's a very unique feature that is in some studies reported up to close to 89 to 90% only seen in COVID-19. In this particular patient, again, we're seeing vascular distension. We're seeing an area of organizing pneumonia, where on the iodine map, we're seeing increased iodine uptake at the peripheral aspect of this area of organizing pneumonia, maybe hyperemia. And then more distal to this area of hyperemia, we're seeing areas of infarction that are occurring due to a microvascular thrombosis. One thing I would say on dynamic perfusion, where this example is one of dynamic perfusion, we can see just concentrate on the right lower lobe, but we can see there's no real opacities present within the right lower lobe. Yet on the dynamic perfusion, you can see the increased red and yellow indicating increased perfusion to an area where there is no real abnormality, also indicating maybe the presence of hyperemia due to the presence of underlying microvascular thrombosis that we're not appreciating on the CT. It is beyond the resolution limits of CT. An example from our institution in an area of ground glass opacity, we're seeing this tubular structure, which is an enlarged vessel, again, leading maybe to microvascular thrombosis or loss of normal hypoconstriction. And we can see on the iodine map, we can see these areas of increased yellow and red, indicating areas of increased iodine uptake, hyperemia, and the blue areas are the areas where the normal lung perfusion is occurring. And this can be verified with quantification of iodine. If we look at this particular example on your right, in this area of increased orange color in the peripheral subfluid distribution, we can see iodine density of 3 milligrams of iodine per cc of tissue compared to a normal area of the lung, where we're seeing 0.8 milligrams of iodine per cc of tissue. So a big difference of iodine distribution, indicating abnormalities of perfusion that are occurring in the lung, even in patients without visible pulmonary emboli. The prothrombotic state in this particular study in an ICU population that was examined of 369 patients, 337 patients underwent CT pulmonary angiography. There was a high prevalence of pulmonary embolism in this ICU population of close to 22%. And the atoll sign, or the reverse halo sign, was a very worrisome sign that warranted workup for pulmonary embolism. Just move forward. I'm just going to move forward here in the interest of time. Now, follow-up imaging, we are recommending follow-up imaging in these patients. And if we look at greater than 3 weeks after the initial onset of CT findings, the evolution is consistent with organization and fibrosis, lung cavitation, and traction bronchiectasis. It has occurred, and we are seeing this in some of our patients. And it's important to note that 66 of 70 patients in this particular study had residual ground glass opacities before discharge from the hospital. So we're commonly seeing patients that are presenting back to our department that have been discharged with the diagnosis of being normal clinically. They've actually recovered, but when you actually speak to these patients that are returning back to our department, they haven't really recovered when you're doing CTs. We're starting to notice that they are having features of traction bronchiectasis and fibrosis after 3 weeks after the initial onset of CT findings. In the differential diagnosis, this is a case of SARS, the initial disorder, severe acute respiratory distress syndrome. This is the paper that we published in the New England Journal of Medicine, where we see ground glass opacity. It was reported that is more unilateral than bilateral, but it's very difficult to say. It is also more confluent instead of having the round ground glass opacities that you see in COVID-19. And doing an initial analysis of our SARS patients at our institutions, we did not see the vascular engorgement that I talked about that we saw on the duology scans that I talked about early on in the talk. MERS, and these are cases shared by my colleagues in the Middle East, more consolidation, more development of complications such as pneumothorax, and more development of cavitation and traction bronchiectasis in patients with MERS. More severity of disease is what I would say. Drug toxicity with ground glass opacity is also considered differential diagnosis. Pneumocystis pneumonia with ground glass opacities, usually in an upper lobe distribution. Respiratory syncytial virus infection with nodularity and ground glass opacities, and also active tuberculosis with more confluent nodules and cavitation. I'll just talk briefly about some extrathoracic manifestations, and what I would say, cardiac, CNS, enteric, and musculoskeletal. One thing I would say about cardiac manifestations, these are classified in myocardial injury, arrhythmias, and heart failure. Myocardial injuries being the most common, usually non-ischemic and ischemic, whether it be myocarditis or type 1 or type 2 myocardial infarctions. Now, at our institutions, we do have a CT protocol for both STEMI and non-STEMI activations. It is the same protocol, and usually a STEMI activation, it goes against what has been taught that you need to go straight to the cath. But patients that have a high likelihood of COVID-19 will go straight to the ER scanner with a prompt cardiac CT angiography. And if it is non-obstructive, they will undergo conservative therapy or transfer to the CCU or ICU. If it is non-diagnostic or there's an obstructive disease, that will go on to an emergent coronary angiogram. And that is the protocol that we've activated for patients with high likelihood of COVID-19, both STEMI activation and non-STEMI patients. One thing I would say about echocardiography, it's indicated in high-risk hemodynamically unstable patients with massive pulmonary embolism. You can see right ventricular dysfunction. You can see right heart thrombus, which is known as the McConnell sign, and also with acute cardiac injury and cardiomyopathy and cardiogenic shock in the ICU settings. There's ongoing studies at our institutions for the role of echocardiography in the setting of COVID-19. What I would say regarding the brain involvement, the literature has reported that you can get a toxic encephalitis from COVID-19. The more common finding, though, with a recent paper that was published in the New England Journal of Medicine as of today, the most common finding is usually an ischemic insult to the brain. So if there's suspicion regarding these patients with neurological symptoms, we do recommend a CT angiogram with multi-phase imaging and perfusion imaging, as some of these patients, even in young patients, have had large vessel occlusions that have indicated, acute infarcts that have gone on to endovascular therapy. Gastrointestinal manifestations, they're not uncommon. In one of the studies, bowel wall abnormalities were seen in 31% of CT scans and were associated with ICU admissions. And usually the most common bowel abnormalities were enterocolitis and bowel ischemia. And usually with bowel ischemia, if you see bowel wall thickening or either hypervascular enhancement or decreased enhancement of the bowel, depending on what stage of the actual ischemic insult, then it raises the concerns of ischemic colitis. We use dual energy CT at our institution that shows decreased iodine uptake that increases your confidence in the diagnosis of ischemic colitis. Now, at our institution, our surgeons really wanted, let me just go back, a protocol instituted. So at our institutions, in the acute setting, any patient that has a high suspicion of COVID-19 that presents to the emergency department, they undergo a PCR test, but that takes at least anywhere up to 24 hours before the PCR test is, the results are relayed to our physicians. So any patient that presents with an acute abdomen or has symptoms undergoes a non-contrast CT chest, and then we characterize it for the features of COVID-19. If the features there are no suggestive features for COVID-19, then the isolation for the COVID-19 could be removed, and encourage observation for these patients is done instead of going on to surgery. If the CT findings are positive for COVID-19, they're isolated, and then management decisions are made depending on the clinical symptomatology of the patient that presents with the acute abdomen. The other findings that we see are cholestasis with dilated sludge-filled gallbladders, suggestive of cholestasis and gallbladder wall thickening. Another feature that we can see is periportal edema or starry eye pattern that you see on ultrasound with acute hepatitis. What we are seeing as well is myositis, and in the external obturator muscles, we're seeing increased signal on these STIR sequences, and myositis, although it's rare, has been reported and maybe a direct injury from the virus itself, or maybe from the cytokine storm. COVID-19 in pediatrics, what I would say, it's milder clinical symptoms, fewer positive CTs, less extensive involvement of imaging. Usually you'll see bronchial wall thickening is more frequent on CT images in comparison with adults. So you'll see bronchial wall thickening with ground glass opacities and consolidation in the left lower lobe in this particular patient. A recent disorder that's been described, the inflammatory syndrome associated with COVID-19 case series that was recently published in radiology that showed that the cardiac MRI findings in these patients, it was not insignificant, is what I would say. It was consistent with myocarditis, is what I would say. But the key feature in myocarditis in the pediatric population is that there was no delayed enhancement on gadolinium, indicating scar. Rather, there was extensive edema on T2 weighted imaging. One thing I'll say about ultrasound, it is utilized at our institution. And what I would say, I'm not an expert on ultrasound for COVID-19, but our emergency physicians are using it more and more. And basically, if you see either linear or confluent B lines, these common tail artifacts that course vertically from the pleural surface that is also thickened, it is suggestive in the appropriate clinical context that you could be dealing with COVID-19. You can go from a score of 1, where you have single B lines, to more confluent B lines with increasing common tail artifacts, and all the way to a score 3, where you can have even more significant confluent B lines, indicating more severity of disease, and also consolidation that can be seen on the ultrasound, verified on chest radiography. But there is a lot of work now that's been utilized to use ultrasound as a screening tool for COVID-19 in the emergency and ICU setting. With that, I will end my talk, and I will thank you for your attention and time, and I'll answer any questions during the question and answer period. Thank you for your attention.
Thank you, Prof. Nicolau, for that exhaustive and detailed and certainly very informative lecture. Before we go on to the next speaker, for those who have just joined us, there will be a question and answer session at the end. So you can ask your question by using the Q&A button, which can be found on the bottom part of the toolbar. Okay, our next speaker is Dr. William Parker. He's a final year resident at the UBC radiology program. Although still a resident, he is probably of consultant grade in the area of innovation. He co-chairs the Joule Innovation Council. He has been a judge at innovation-related competitions. He is a member of the Royal College Technology Task Force in Ottawa. So we are very happy for him to give a talk on AI-assisted CT as a problem-solving tool in managing COVID-19 patients and predicting outcomes. Dr. Parker, please.
Thank you. Thank you very much for having me. Can you hear me okay?
Yes.
Excellent. It's an honor. Thank you for inviting me to speak today. I'm wanting to talk a bit today about AI and how it relates to COVID-19 and what we're doing at our institution. Dr. Savas Nicolau and Dr. Umar Nasir, really supporting all of my efforts with the team at UBC to develop this technology and push it out for the world to use open source. So I'll talk about this project and how we're developing it. And then I'll talk a little bit about some of the software we're also releasing that helps institutions around the world anonymize medical imaging data. And so at your institutions in Singapore, you're more than welcome to go to our websites and check these out. So just quickly to get started, some basic terminology in AI. So artificial intelligence is a subset of data science where you use neural networks in order to solve problems and make predictions with respect to whatever data that is being presented to you. And there are 3 kind of levels to understanding that we have. We have an architecture, which is I'm sure you've seen diagrams like you see in the top right, where it's like a schematic of how a neural network or a model is developed. It doesn't talk about what it's coded in or what the results are going to be. It just talks about how it's laid out and set up, and we call that an architecture. There are many examples, such as a neural network, an eigenvector, a generalized adversarial network, many different types. Popular in media right now and being used in medical imaging is the neural network or the deep neural network. Then there are things that are called algorithms, and architecture, algorithm, model. These are all words that are used interchangeably, but they have some very subtle nuanced differences that I'd like to point out. So in an algorithm, you're actually talking about the software language that is coding the architecture. And so it's very specific. And an algorithm is mixed with and trained with the data, say the CT images or the X-ray images, to make the model. And so these are important differences, and I'll be using this terminology throughout the talk. So Today I'm going to be talking about using CT scans to train neural networks to detect COVID-19 and other pneumonias on chest CT scans. So Dr. Nicolau, myself, and the team at VGH and UBC have worked closely with Siemens Healthcare and been data contributors, as well as provided some input into development of their CT model for COVID-19. And so I recommend this model obviously isn't open source, the one that was developed by Siemens, but they've done some excellent work with their theory and their processes behind developing their models. And so there are a few great ArcSiv articles, and I think a few articles coming out in RSNA publications soon related to that. So just wanted to make mention of that. But at our institution, we developed and are ongoing developing a CT chest AI model that we're releasing open source. And this is what it looks like. It's available to everyone to use. Right now, we've released our first version, which is just the raw code with all of the weights. And so if you have some coding experience, you can go to our website and get to the GitHub page and download the model. There's also a demo on the website, so you can go through and see how it works. And I'll talk about this near the end of the talk again. So when we set out to make this CT model, we had two hypotheses at the beginning. The first was, can we identify characteristics that are unique for geographic regions from a clinical perspective on imaging? And so we went to or Dr. Nicolau has an extensive network of colleagues around the world who he's reached out to, and we've collected a large data set of CT scans positive for COVID-19. And we're ongoing analyzing the appearances on CT. And then from a data science perspective, can we develop a model that accurately classifies SARS-CoV-2 and then segments the abnormal areas and classifies those patterns, which Dr. Nicolau talked about in his talk. Classically, there are 4 steps in developing an AI model. And that is data collection and planning for the types of data that you want to use. Data preparation, which includes anonymization and labeling. The training of the algorithm itself and taking that algorithm, adding data to it to make it a model, and then taking that model that's now been trained and testing it in the clinical environment. And I just want to point out here that the mass amount of time that takes to develop a model is in all of the data preparation and planning. It's significant, and I think that's under stated a lot of the time. A lot of people like to focus on the model and the outcomes, but that is the least amount of work, and the significant amount is all in the data prep. So in our project, our network was extensive and vast, and we were able to reach out to many colleagues around the world to collect data. And these are some of them here. We're very lucky to have these collaborators, and this project would not be possible without them. So we collected the data, we brought it to Vancouver General Hospital. We use Amazon Web Services and cloud environment to aggregate all the data. And the next step is, once we have this data, whether it was anonymized before sending or we anonymize it once the data got here to our institution. We made sure we anonymize the data, and that's really, really important. The first step in medicine is do no harm, and releasing patient data in a vulnerable population who are going through hard times such as COVID-19 would be unethical, and in many jurisdictions against the law as well. And so it's really important, if you're going to be doing any of these projects, to properly anonymize. And so we've developed this software. You're welcome to go to our website and download it. It's free for anyone to use, and it's an easy way to anonymize DICOM medical imaging data. I'll walk through it really, really quick. You open it up, it looks like this. You can name your data set. You can identify a folder by clicking here and finding the folder of input. And then in the output folder, you can select some of the parameters like the requisition, or make sure those are removed. Standard anonymization is the HIPAA compliant one, but HIPAA doesn't follow actually all of the as strict as we like to do. So we tap into custom when we anonymize for institutions, and we select only the ones we want to keep, and then it removes everything else. And so it's really powerful for anonymization, and an important first step for any of these data science projects. So we talked about this a little bit. Our software's whitelist, which I think is really important. Select the ones you want to keep, and it removes everything else. But it's really, really important to pay close attention to anonymization and encryption before getting started on a new data science project. So once we've anonymized the data, then we labeled it. And just a few data points for the first phase of our project. We collected around 2,000 studies and had them labeled. Some of them were open source to get things started, and then we got through about 1,100 studies for our first phase. And we're labeling ongoing after we release the first stage. So the model is still in development currently. We've labeled a significant amount more since. We still have quite a few studies at this point when I made this slide to label, and so that's ongoing. But at the time, we got through almost 30,000 slices and 4.85 billion pixels. So a significant amount of work done by the teams at VGH. And these are some of the staff, residents, fellows, and med students that did the most labeling. And so just to kind of give a perspective on how much time and effort would go into these, it's about 30 minutes per study, and one annotation's about maybe 50 pixels, and so it's a lot of effort to get up to 63 million pixels, as you might imagine. This is how big our labeling team was. Significant amount of effort and work going into labeling. And Dr. Umar Nasir is here, and we thank you very much for helping with all of that. It's excellent. We can't do it without labelers. We use this software here, MD.ai, and this is a software that we paid for. It's a company out of the States, but they can install it onto a local server. And so if you have some data that you want to work with data scientists on, I recommend this software. And basically, you set up the labels as you would like for the data project, and then you just you have your annotators go through and just label the areas. And it becomes relatively easy. It does take time, but having software like this makes things much, much easier. There are challenges with labeling. So as I mentioned before, labeling can take time, and sometimes for beginners, it can take up to 90 minutes for a study to manually label the lungs, manually label the opacities, characterize the opacities, and identify whether or not the radiologist thinks that the study looked like COVID-19. And so, we go through processes to decrease that effort. Things like entropy, where entropy is this idea of where there's confusion or randomness in the universe. We can apply it mathematically to the model, where the model finds areas of confusion. It increases that on the heat map, and so areas of red are more confused, and then you can have the labelers focus in on that and label a bit more efficiently. And there are many other processes to help increase efficiency of labeling to make it more cost effective and time effective. And so we've done some testing on this, and we're currently implementing processes amongst the labelers for phase 2 with entropy-based labeling. The other challenges are IOU. When you're actually segmenting opacities that have relatively indistinct margins, as you can see here, some margins are more sharp, others are more graded or shaded. And so, is this a good label, or is this a good label? Maybe it's somewhere in between. And so using an IOU calculation, where I'll just go back, if you look at these IOU calculations, having a label that's like this here is only 0.4, which is not a great IOU score. But when you move forward and you look at some of these, this would probably be about 0.4, 0.5, but to a radiologist, maybe those labels both aren't so bad. And so it becomes challenging from a mathematical perspective to assess accuracy of a model when there's this kind of subjectivity to it. So we've been working through mathematical heat maps that help to create improved probability metrics to assess accuracy. And so then once we get through the data labeling, then you want to train the model, and train the model and training a neural network. Now, there are many different ways to do it, and there's lots of theory behind this. But if you have any data scientists at your university or institutions, there's lots of models they can pull off the shelf and train imaging AI relatively quickly. And all of these models basically approach training the same way. They'll take an image like this. This one's been cropped, but it's obviously a CTU and bone windows, and it'll reformat it, create a topography assessment, kind of like this, where on the z-axis you have Hounsfield units, and then the x and y is just the pixel. And you can see that there's lots of internal slope and character to the data set that we're using all the time as radiologists to assess window and level. And if you adjust those and you do mathematical equations that invert or change the absolute value of the slope of these gradients, you get these filtered projections that start to elicit certain features from the image. And when you match these features to labels and you do a combination of these filters, that's where the model starts to learn from. So these are some of the filters that were used in the creation of our model. Just interesting to see some of the characters that the model is looking for. So here is an example of the output from the model when we're training it. So what we get is these kind of distributions of images. On the far left is the original image. In left middle is the label that the radiologist segmented. This is the model that's never seen this image before. This would be called the test set. So the model, we're trying to see how well the model is doing in relation to the label. And then the opacity probability, where we're trying to figure out better metrics to assess accuracy, where instead of it being a harsh line, there's more of a gradient scale there. And so as we go through this study, I'll go through it relatively quickly. You can see in this example, the model is looking for different patterns of opacity, and there is some difference between the label and the prediction, but the absolute segmentation is relatively good, and some of that subjectivity is seen with even intra-observer variability. So we're starting to get down to this interesting space of who's more correct, the machine or the human, and we're going back to the drawing board on how to better assess these metrics and understand how to move forward with this. So interesting. Model testing and validation. So once we've developed a model, we deploy it in the clinical setting and see how well it's done. And so this was our first step. As I mentioned, this is released on our website. You can go visit it and do this yourself, but the demo shows has a bit of a control metric on the side. You can adjust the opacity. You can scroll through the CT, see how the model is done in relation to the opacities. And then you can see the metrics here on the far right, where we have the different types of opacity: pure ground glass, the crazy paving, organized pneumonia, and consolidation, as discussed in Dr. Nicolaou's talk. And all these patterns correlate with different probabilities of outcomes and requirements. And so having these percentages hopefully will really help the clinician and the radiologist in adding value to the clinical team. We also see here the percentage of lung involvement and the percentage of a well-aerated lung, and the classification of COVID-19. And this is all available open source, so anyone can use it. So back to goals and clinical relevance, and then I'll wrap up. So basically, this model does three really important things that make it possible to quantify. It identifies it segments first the lung, and then it segments the opacities within the lung: the ground glass, the consolidation, organizing pneumonia, crazy paving. And it calculates a percentage of lung involvement, irrespective of the type of opacity. That's the first thing. So we get that percentage and that absolute liter volume of involvement. The next is to identify the opacity pattern. Which intrinsic pattern is this opacity? And then the final thing is the COVID-19 classification based on the RSNA consensus. And why are we doing all of this? Well, papers have shown, this is a study out of Italy that showed percentage of well-aerated lung correlate with ICU admission and death. And so in this paper, they showed that any percentage of well-aerated lung that's less than 73 or 71% these patients ended up doing worse. And so using a model that can accurately calculate this percentage will hopefully help clinicians better understand what predictors lead to poor outcomes. And then, further, going one step further, instead of just having an absolute value of any opacity, well, can we break it down into these patterns and see, well, if it's more likely to be, if more of the lung is in consolidation and less of it's pure ground glass, well, maybe that means the patient's going to do worse than just the pure ground glass in more sometimes we see it in the earlier phases of COVID-19. So these are some of the things we're looking into now and seeing which patterns and which combinations of patterns quantified can do worse for patients. And then the final thing that the model does is classify it, like I said, based on the RSNA consensus statement, these 4 categories. One thing that we're looking into, and as Dr. Savas-Nicolau pointed out in his talk, the sensitivity of PCR is not 100%. In fact, literature says between 60 and 70, 80%. And so can CT be a tool that adds value? And we believe it can. And so, some of these papers show that the sensitivity of CT is significantly higher. This paper on the left talked about 97%. I think we're starting to see that that's not. We don't think it's that high. This other paper talked about sensitivity in the 70s. Maybe that's a little bit on the low side, but what we're seeing at our institution is probably somewhere in the middle. And so hopefully CT in an adjunct to the clinical setting and in the setting of a negative PCR can help with better inform the clinical teams to isolate and take care of the patient and also protect the healthcare workers. I want to close and just say thanks for having me. I'm honored to be able to share this project. We're very lucky at UBC to be able to do something like this. It's a large team of people that have helped make this possible with partnerships. And hopefully, if you're interested in data science or AI, you'll check out the model we've created so far, and we'll be releasing a new version in the coming months, and so we hope that you get to see it and potentially even use it. And if you have any questions, please reach out. So thank you very much.
Thanks, William, for sharing. Again, before we go on to our last speaker, for those who have just joined us, I noticed about 280 participants have joined us. We have a question and answer session at the end. If you have questions, please feel free to write them using the Q&A button at the bottom of your toolbar. Okay, last but certainly not the least would be Dr. Charlene Liu. She's a senior consultant radiologist at the Changi General Hospital in Singapore. She's also currently the chairman of our chapter of diagnostic radiology in our College of Radiologists. Charlene is also very into AI. In fact, she's the radiology lead for AI projects in her hospital, as well as our health care cluster, the Sing Health cluster. Today, she'll be sharing with us an AI tool to predict severe pneumonia outcomes from chest radiographs. Charlene, please.
Hi, everyone. Good afternoon. Thank you, Prof, for that very kind introduction. And I'm extremely honored to be invited to give a talk today amongst the company of very distinguished clinicians and AI scientists. So I guess I'll just start by acknowledging my team, which is, as you've seen, William's team is just as is as large as ours. So we have a huge team of people who actually have made this happen. Certainly data science is, as William says, the majority, the huge chunk of the work is actually in the data preparation and not so much so in the processing and the computation process. So, it takes a lot of people to make it happen. And this actually represents a collaboration between clinicians, radiologists, as well as data scientists. So I can say it's really, truly a collaboration. So I have no disclosures to make. So just a bit of a backstory to how I got started in on this project. So in the early months of when COVID was just beginning as a pandemic worldwide, we found that as radiologists, we were busy coming up with the guidelines, for safe scanning of patients, and how to reorganize the department around COVID. But far from just doing that, and as well as we felt standing by at the sidelines and helping with the reporting work, we felt that we could actually do much more. And coincidentally, I mean, all the projects that we have been working on, all the research projects that were ongoing in the hospital were actually halted. They told us, put them on hold, and only COVID-related projects can actually go forward. And so all of our other AI projects were also, put on hold. And so we started to brainstorm as a group, what can we do with, with our AI tools, with our AI knowledge, which is very much in its infancy, I would say, in Singapore. We are by no means, world class in that sense, but we're trying very hard. Obviously, as you've heard, our government is also supporting us, and we're trying very hard to build it up as a future, as a part of the future economy. And so in the early stages of COVID-19 in Singapore, although we were one of the first majorly impacted countries around the world, our numbers did not really climb very rapidly. It was only in the beginning of March when suddenly we saw a rapid rise in the number of cases. So as you know, with data science, with AI, it's quite difficult to actually create models for training without sufficient data. And so we were kind of stuck, and we had to think around the problem. And I guess here's where a bit of innovation came in. I consulted one of my colleagues, Jessica. She's actually, listening in as well. And she's a co-lead in this project. So she's a respiratory physician. And incidentally, she had been developing a registry for community-acquired pneumonia patients, for her research. And so she had actually collated very high-quality research-grade data over the years. And so we were sitting on a very large data set, which we potentially could use to train, in anticipation of a potential spike in cases. And I don't know if it's a good thing, but I think definitely it's not a good thing, for our patients. We then experienced a huge increase in cases in April. Okay, from our population of foreign workers in the dormitories. So that became a huge burden upon the healthcare system in Singapore. So I guess fortuitously, by that time, we had already started to work on this project, and we rapidly built a model. So giving you that background, I guess we'll just go into the nitty-gritty of how we actually went about doing this. So as you know, COVID-19 has really pushed all healthcare systems around the world to the edge, and it's really spurred the rapid development of AI health informatics solutions. And we can really see this push towards digitalization. And people have said over the past few months, we have managed to motivate change around the world towards digitalization, a task which would have probably taken 10 years, but we've done that in a few months because we had no choice. So the most current prognostic scoring tools for the disposition and severity assessment of COVID-19 use either radiology images or EMR data, so either or, not both. So our team worked on developing the first machine learning model to augment these in a single end-to-end machine learning model. So Our model actually can discriminate between mild and severe cases of community-acquired pneumonia and COVID-19 on the first day of inpatient admission for clinical decision support. And very early on, our hospital senior management and the health task force at the Ministry of Health did enunciate that this was one of the major questions that we had, was how do we actually predict which of our COVID patients will become severely ill and require ICU admission? Because at that point in time, the concern on everyone's mind was that we would not have sufficient ICU beds to support the severely ill patients. And so we thought that this was a very important question to address. And we actually feel that in developing AI models, the most important first step is to make sure that you have a clinical question that is worth the trouble and the effort in building the AI models. That is actually a firmly held belief that I have. So anyway, the final ensemble model had a higher performance compared to the model using only imaging, chest X-ray or EMR data alone. So it had a higher area under the curve and accuracy. And when we tested it on real-world clinical COVID-19 data, it actually held up. So we also developed a simple and to implement standalone application that is integrated to our existing RISPACS clinical workflow. So there are other existing scoring tools for the assessment of pneumonia. And indeed, COVID-19 is a form of pneumonia, community-acquired pneumonia. It's a type of viral pneumonia, but nonetheless, it is a community-acquired pneumonia. So the efficacy of deep learning-based algorithms based on chest imaging have been demonstrated to be useful in the past for pneumonia diagnosis and discrimination of viral from bacterial pneumonias. So it's already well known that deep learning AI can actually do this. So the machine learning techniques using EMR data could also predict whether or not patients at emergency departments would require critical care services. And this has actually been published in the literature. So there is an unmet need for a unique population-based automated pneumonia and COVID-19 assessment tool that can rapidly stratify disease severity to enable clinicians to effectively triage patients, both at the acute hospital setting and also potentially, in the dormitory setting or in these temporary field hospital settings where you have thousands and thousands of patients. Most of them are quite well, and you would actually like to know a few days ahead of them deteriorating so that we can increase the monitoring that we implement for them, and as well as perhaps transfer them to hospital earlier on so that we can actually keep a close eye on them. So the so-called CAPE engine, which we built, it's a COVID-19 AI predictive engine, so it's an acronym for that, was developed using 2,169 chest X-ray images and over 200,000 data points from electronic medical records. So we've run a pilot in our hospital, Changi General Hospital, since the 9th of May. And our research team actually acquired about 100 independent variables from EMR that are hypothesized or known to be related to severe disease in COVID-19. So the tabular data set was actually segmented into 4 parts: demographic characteristics, information about past hospital admissions, so what were they admitted for, past medical conditions, and laboratory results on the day of admission. So the predictors were generated for machine learning algorithms based on the search of the literature and also input from our clinicians. And we experimented with various different ensemble techniques to augment the X-ray and EMR data set. As you can see on the right-hand side of the screen, so we tried multiple inputs and mixed data. We tried weighted risk scoring. We tried sequential stacking. So we tried various ensemble methods to combine the data. So the predictive model developed using the retrospective study cohort of adult patients admitted from the beginning of last year, 2019, to the 30th of March by emergency department with a diagnosis of pneumonia was used as the training data set. So the study cohort training data set had 3,048 chest X-ray images from 2,902 unique adult patients. And it was de-identified, validated, and it was split into a split sample validation. So we had a training set, a validation set, and a final test set as well. So the CAPE application itself is a standalone desktop program. So it's installed upon one of our workstations in the department. And the patient data, therefore, does not leave the hospital's network at all. And in fact, since our hospital's computers are currently air-gapped as well, it does not even leave the computer. So it was implemented in Python for integrating our TensorFlow-based deep learning models. And we use an open source tool called Panel to lay out widgets from various IPython notebooks into a web-based application. So I actually launched it from my browser, my Chrome browser, and we add user interactivity into it. So that actually reduced a lot of time, in the development effort. There's a virtually building from previously available building blocks. So this is actually a actual screen grab of a test patient, as you can see. And so this is what it looks like. It's very simple. The layout is extremely simple. It's fairly intuitive, I would say, and it's very user-friendly. So as you can see, it was designed for use by radiologists. We have a little, I wouldn't say a thumbnail, but close to the thumbnail, a little picture of the chest X-ray and an overlaid heat map. So for those of you who are new to artificial intelligence in imaging, a heat map is where we overlay a kind of color-coded kind of map so that you can actually visually know where the deep learning system is actually activating at. In other words, where it's looking at. So in that way, you can actually cross-check and double-check the work that the AI is doing. So in a way, it is a form of explainable artificial intelligence. And indeed, we're actually working quite hard to increase the explainability of the black box of deep neural networks. I think that's a very important part of the work, and it will actually greatly increase our trust in using artificial intelligence, and also the clinicians when they use AI models. So as you can see on the left-hand side of the screen, the areas that are almost bright yellow to orange and red, those are the most activated areas. So it's actually, in this case, is activating over the area of pneumonia. So this is how we can determine that it's actually looking at the right thing, and it's not actually giving us an erroneous result. So you can see on the right-hand side of the screen, there are several predictions here. This is not the full model. I'll actually show you another screen grab of the full model, but here we have the mortality indicator, a 3-day mortality indicator. So we actually have a horizon window here. So we have a kind of like, I like to say, a crystal ball, so that we can look into the future. What is this patient's 3-day mortality and the 2-day ICU admission risk? So this is a combination of, as you can see on the right-hand side of the screen, the image classification deep learning algorithm, as well as EMR data combined. Okay, so here is actually a very rough schematic diagram of how we plan to implement this into our workflow. So the discussions that revolve around implementation into a hospital's clinical workflow is not a trivial question, I must say. And in fact, it is one of the things that we have to start the conversation very early on. When we're planning this, we have to speak to our ED physicians, we have to speak to our respiratory colleagues to gain their buy-in and support, because at the end of the day, in order to implement these solutions, the only way we can do so successfully is if they actually use it, if they actually use the input that we're giving to them. So just briefly, you can see that we have two sources of data, EMR and chest X-ray. It's inputted into CAPE, and the CAPE engine actually pumps out the mortality, for example, here 85%. And the radiologist reports the X-ray, and actually appends the CAPE results into the diagnostic report. And the alert is actually sent to the ward if, let's say, the risk predicted value exceeds a certain preset number, for example, 75% in this case. And the ward doctor actually confirms the findings clinically. So, you know, if, let's say, the indicator is 96% risk of mortality, the ward doctor can then, you know, go to the patient and examine them and see, you know, if the parameters are pointing towards that direction. So that's how we envision that it could be used in a workflow. And again, on the right-hand side, this is another screen grab. Now, this was the more the finalized version. So you can see we actually produce several outputs, prediction outputs. We actually computed the length of stay risk to be greater than 2 days, inpatient mortality risk, inpatient ICU admission risk, and inpatient critical care usage risk. And here are some nuggets of insight that we actually obtained from doing this study. So interestingly enough, when we looked at the top 10 variables that influence the, you know, or had the predictive power in this CAPE engine, chest X-ray images were actually of the greatest importance by a wide margin. So you can see that, you know, we're talking about magnitudes of scale here. So almost 5,000 to 500 to 5,000 times more predictive power than other variables such as CRP in this case. So it was quite an interesting insight to learn. Yeah, so on the right-hand side of the screen, here again, you can see another heat map. You can see that the areas of activation coincide with the areas of ground glass change. So this actually aids the clinician in making a further clinical assessment, whether or not to use the model, whether the results can be actually trusted. And we also envision that that this kind of machine learning model is very quick and is relatively easier to implement in, you know, for triaging and right-siting care in, especially in resource-constrained countries, which might not have access to, you know, CT scanners. And also, it actually cuts down upon the time that's required to do the traditional risk scoring method, which actually takes a lot of time. If you're talking about you know, looking at the traditional risk scoring from other pneumonias or community-acquired pneumonias, is a manual process in which you have to actually take down the variables and manually compute. So it will actually save a lot of time, and it's actually helpful in a resource-constrained setting. So here are the results actually. I'll just briefly show you the results. So this was for length of stay. The ensemble model actually produced an area under the curve of 0.77. For pneumonia, and for COVID-19, it produced a length of area under the curve of 0.71. So the highest accuracy was always achieved by doing a sequential stacking ensemble method. And here are some ROC curves. You can see for COVID-19, you can see the area under the curve was 0.71, and for community-acquired pneumonia was 0.77. And here is the overall model performance overview. These are the different models that we tested. So length of stay, less than 2 days, area under the curve, 0.77. Mortality, 0.89. So this was the highest area under the curve that we could achieve, was for mortality prediction. And ICU admission, 0.85. And this is just a detailed analysis of the various you know, false positive and false negative rates. But I think I won't dwell on this. Okay, and finally, I think this is what we like to, you know, the proof in the pudding. These are actually real life patients. So when we put the AI to the test, in the top row, you can see a 42-year-old man with positive PCR for COVID-19 infection. So here is the actual chest X-ray. And this is the AI model with a heat map overlaid. So the deep learning risk score for this patient for critical care admission was 80.6. And he was subsequently admitted to ICU for deteriorating oxygen saturations. And at the bottom row, you can see another chest radiograph from a similar age range, a man, 47-year-old, with a positive PCR test again. And this was the frontal chest X-ray on admission and deep learning model with the heat map overlaid. So you can see that the heat map in this case is hardly activating at all. So the deep learning score was actually 17.8%, and he did not require ICU admission during his admission. So just some cases, just to show in real life how we have been testing this model and the real life outputs that we see. So in summary, we have many other steps that we need to take in order to validate this further. So in order to ensure generalizability, we need to validate the same model at other tertiary healthcare institutions within our cluster, SingHealth, and also outside the cluster. So we have already made plans to work with other public healthcare institutions to expand our pilot run for this model. Also, we would like to say that collaborators who are interested in deploying this software internationally are more than welcome. We are currently in the process of writing this for submission to a journal. And so once we publish, we will actually release this model as an open source website, which will be actually described in that journal publication. So from a system perspective, we plan to actually integrate the DICOM service class provider within CAPE. And that actually enables our AI system to directly receive DICOM images in the future. Currently, it actually, what it does is it takes the DICOM image, and we have an intermediate application which actually converts DICOM into a JPEG. And that is because current AI models actually train on JPEG, and they actually work on JPEG images. So in the future, we hope to change that to a DICOM model instead. And that will obviously enable a more seamless transition from modality into the AI system, and hopefully also increase the accuracy of the model. So in summary, I think that is, in conclusion, that is what we have done in Singapore for COVID-19, and we have started at the very at the very baseline, which is chest X-ray, in the hopes that we can actually produce a very useful tool for everyone to use internationally. Yep. So, and with that, I would like to thank you, and I'll pass it back to Prof. Tay. Thank you.
Nice presentation. I'm just watching the clock. We probably have about 10 minutes or so for question and answer. Surprisingly, today we have only one question on the Q&A function, and that question was regarding, I guess, quite a common question actually. Can AI possibly result in radiologists becoming redundant? And I believe William has already answered it online. But I guess the other speakers can chime in. But before that, I would like to ask Dr. Sabas, the dual energy CT scan of COVID-19 patients. I thought it was very interesting that you are able to use dual energy to predict or infer micro embolic events. I have to say that the thromboembolic complications in Singapore COVID-19 patients are not very common. We don't really see them. I'm just wondering, over in Canada, is that a common problem? And would you recommend routinely to do dual energy CT scans on these patients with ground glass change in their CT?
Yeah, I think that's an excellent question. In our institution, definitely we've seen, particularly the patients that are admitted in the ICU is what I would say to you. Definitely those we've seen more of an occurrence of pulmonary thrombotic disease. What I would say about the dual energy characteristics of COVID-19 patients, I think it's underreported and underscored how important dual energy CT or iodine perfused blood volume maps are in defining the different types of phenotypes that are present in COVID-19. Because on a non-contrast CT scan of the chest, you do see these opacities, and you presume that the abnormality only exists where the opacities are present. But I think the dual energy scans that we have at our institution are showing that with some patients, even without opacities, we're seeing areas of decreased iodine uptake, and then we're also seeing areas of increased hyperemia, or maybe even reperfusion injury that's occurring to the lung, is what we presume anyway, due to these microvascular thromboses that are very difficult to detect on a regular CT pulmonary angiogram. And if you don't see a pulmonary embolism on a regular CT pulmonary angiogram, the exams are actually called negative. But when you do the iodine quantification and the iodine map analysis, you start to understand that these patients have significant perfusion abnormalities. And what we're looking at is actually from an AI perspective as well, is the perfusion and predicting some of these perfusion abnormalities on these patients, how severe, how common these perfusion abnormalities are occurring, because we believe maybe the answer lies in this vascular dysregulation that's occurring, that is causing the significant hypoxia or silent hypoxia or other complications that is occurring in these patients. And these patients, maybe these different phenotypes that are occurring, need to be managed differently from a ventilation perspective, is what I would say. And I think that's what still needs to be discovered. But I think dual energy has a lot of value, in my own opinion, to add to these patients, because even if these patients, people are presuming that even people with D-dimer is one thing I would say now that it's coming to my brain, is in the Dutch study that they did do some dynamic perfusion, even in patients that had low D-dimer values, less than 500 milligrams per liter, what they showed on some of the dynamic perfusion scans, that these patients actually had perfusion abnormalities that had most likely inferred that microvascular thromboses with reperfusion injury to the lung that was not recognized on a non-contrast CT scan and incorrectly managed from a clinical perspective.
Right. And the other question I have, again, for Dr. Savas, the infection control measures that goes into bringing down a patient for scan is quite tremendous in terms of the preparation, essentially to protect our radiology staff, and also the after scan cleanup of the room to prevent cross-transmission to other patients. So in your experience, what kind of throughput are you talking about? Are you able to achieve when you bring down a COVID patient to the CT scanner to scan? Because we have been struggling, our throughput has really dropped quite a fair bit every time we need to bring a COVID patient down to scan. Any strategies?
Yeah, I think that's an excellent point that you make. I think initially, when the experience was not there, I think it took a tremendous amount of time with the level of protection that everybody had to take care of themselves, and also the cleaning that was being inferred to occur. I think with greater experience and greater advice and implementation from our microbiology and infectious disease teams into our institutions, what we've done is we definitely have one scanner that is utilized for all of these patients. I think our technologists do have protective gear and masks and gloves that they commonly wear in that one particular scanner. where these patients will undergo the CT scans for COVID. The second thing I would say, the humidity is maintained at a certain level within the room. Above 70% is my understanding from the head of microbiology, because the infectivity rate, it goes down significantly, or the transmission rate of COVID-19 significantly decreases when the humidity in a room is greater than 70%. And of course, if you had the luxury of having a negative pressure ventilation, and then the room is cleaned within 15 minutes in one of our CT scan rooms. Of course, it costs more money, and of course, if you had proper filtration systems as well. So right now at our institution, it takes 30 minutes to clean a CT scanner between patients, which is down significantly from the past, is what I would say. And some institutions, with the appropriate measure, reporting cleaning times up to 15 minutes between patients. Omar, anything you want to add? And I'll just ask Omar if he wants to add anything as well, because he's done a lot of work in this area.
So basically, after the initial problem in the first few days when we started having patients, so what we actually kind of set up a few guidelines, and we have actually published those guidelines as well in our very first paper from our institution, which was titled as Preparedness to Diagnosis, because preparedness is the foremost and first thing that we should address in such pandemic scenarios.
Yeah, and when I say advice that I would give, I would say identify one scanner. I would say have appropriate protection for those techs to have for themselves. I think speak to microbiology and infectious diseases to properly prepare the room, as you would do for an interventional unit room. And even our interventional units that are doing interventional procedures, the cleaning time is down to 30 minutes now between patients, is what I would say to you, where we do interventional procedures that are extremely high risk, and the CT scans as well. It's down to 30 minutes with the appropriate measures, humidity, negative pressure ventilation, and appropriate protective measures for our techs and our staff radiologists. Because, in our institution, we're a 24/7 site, and we have a staff radiologist on site, and I go into the console room to do a heart read all the time on the scanner for these types of scans. So far, so good, knock on wood. That's what we've done at our institution. That has helped us. I know that some other institutions are putting in portable CT scanners in their parking lots or next to the emergency departments that are scanning these patients as well, not to contaminate the main department as well, and not to impede or cause significant reductions of other patients being scanned as well. So those are some of the measures that people are doing.
Right. Yeah, I'm just watching the clock. Maybe we probably have time for one more question, and this is for both William and Charlene. There's a question about Alibaba Corp has published their AI diagnostic tool for COVID-19, and they claim that with that algorithm, they can differentiate COVID-19 from other viral pneumonias. So do you think it is possible to reliably diagnose COVID-19 just through CT and AI? Maybe, William, you want to take that first?
Sure. Yeah, no, I think it's possible. But I don't think diagnostics are necessarily the best use of AI. Just because we can diagnose with AI doesn't necessarily mean we want to build that, because the radiologist is already quite skilled at that. And when we look at, these multiple diagnostic assessment papers that are coming out for the accuracy of X-ray and CT, I think that shows some significant utility and value from radiology. But what I think is interesting is taking some of these diagnostic models and applying them, like we've seen in the talks today with respect to quantification and prognostication. I think is a much more interesting and useful problem that augments the current value and takes it that much step further. And then further, with a lot of these companies that are advertising, different models, there's a lot of variability in how you interpret the results, and I think you have to look really closely at that. Does Alibaba, are they using a test set that the model has never seen before from a center that it wasn't trained on the same data as that center? And are they using the right metrics to quantify that AUC curve and the accuracy there? And if you don't understand those accuracies, it's hard to really interpret how good a model is and whether or not it'll be useful at your center for your patients. I hope that answers the question.
Yeah. Charlene, anything to add to that?
Yeah, I actually agree totally with William. I think we have to exercise a slight amount of caution when we are dealing with commercial claims, as some of the vendors that we know have announced, all of these claims have not actually published their results in peer-reviewed publications. And a few of these claims have not been validated in reproducibility studies in other countries or different hospitals or different sites. So I think the same clinical rigor that we apply for medications and drug discovery, the same has to be applied to a certain extent for artificial intelligence. I think we are actually defeats the purpose if we buy too quickly into the hype, and it will actually set us back significantly if we lose the trust of the public, by blindly following the claims of commercial entities and other claims without having the same level of clinical rigor. So I think we need to be cautious, but as always, I think we can exercise some cautious optimism that their claims may be correct, and we will just need to reproduce the results elsewhere before we should accept that as at face value. And so that yeah.
Yeah, thanks. I think I will close the session. It has been a really education and informative session, and I think personally I've learned a lot. So I hope everyone has enjoyed this session. And with that, I will close the session and wish you have a good the rest of the weekend. Thank you very much.
Thank you so much. Really appreciate it. Thank you so much.
Thank you.
Bye-bye.
That's great.